joint American Pediatric Surgical Association and the Society for Vascular Surgery. I think there are going to be people in this call who know a lot about both organizations and some who may not know anything about each other, so to speak. So part of this is really to create a community to encourage collaboration and conversation. And I'll be honest, I think for the pediatric surgeons on the call, a lot of this will be relatively review. Although some of the follow-up stuff I hope will be new or at least thought-provoking. For the adult surgeons, I really wanted to give a bit of a framework. Many of you already know this because you participate in some of these operations or cannulations or decannulations, and some of you may be just trying to understand how to engage with pediatric providers and surgeons and hospitals. Let's see, I want to get rid of this little thing here. These are sort of the goals. It's not CME here, but just the goals to talk about cannulation in a broad range of our patients. A particular attention to reperfusion cannula placement, because that's really something that most pediatric surgeons, were aware of, but just maybe not have the facility as one adult might in adult world. Talk about decannulation and focusing on reconstruction. Again, a pet interest of mine is long-term follow-up and the lack of data in this topic, and then really to end up and maybe intersperse ideas about how we can collaborate between our two fields. And this is certainly not limited to ECMO. ECMO is just a paradigm. As background, our plans are to have one in-person meeting at each of the major society meetings. So APSA for us, which is a May meeting, and the VAM, which was, I think was June, July. And then intersperse in the remaining time to alternate a webinar that would be hosted by the vascular surgeon and the pediatric surgeon, and then really address a bunch of topics. At the last meeting of APSA, we talked about dialysis access and a little bit of trauma. And then at the VAM, we did some case presentations, and then also be ECMO, but there's lots and lots more to talk about. On the Society of Vascular Surgery side, we have a big task force, but the two leads are Don Coleman, who's the chief of surgery at Duke, and then John White, who's a vascular surgeon at Advocate in Chicago. Both are very active in the SVS. And then on the APSA side, Regan Williams is the trauma medical director at LeBonheur in Tennessee, in Memphis, and a pediatric surgeon there. And I'm here in Seattle Children's, these are the, I hope I got everybody. These are the task force members who've been super helpful to us to generate ideas and talk about projects and bounce ideas off of, I think, some, and hopefully many will be on the call. This is the outline. We'll try to keep to time. Regan's going to give a presentation on neonatal ECLS, talking about congenital diaphragmatic hernia. Again, for the pediatric surgeon, this will be a little bit of review. A very brief overview with me and Dr. Coleman about what is ECLS in the pediatric populations. Why do we put kids on? What approaches we might use and where we might overlap with vascular surgery. Another great presentation in a slightly older child. I'm going to show you a little bit of data from our ECLS registry, talking about carotid and femoral imaging post decannulation with or without reconstruction. A tiny bit of literature review on the follow-up. It's really been an interesting evolution over the last 3 decades about what people have done to follow their kids, which is not as much as I hope we can do moving forward. And lastly, really a sort of adult-sized patient that we still address in children's hospitals with a bad problem, and I'm going to lean on Dr. White to help think through how we cannulate in again sort of more adult-sized patients and what are the pitfalls and stuff like that. And lastly, I hope we have time. I programmed in time, and I hope we have a chance to chat amongst us and talk about sort of future steps. I think I'm going to pivot. So this is going to be Regan's recorded talk, and please let me know if something doesn't work well in terms of audio.
Good evening, everyone. I want to start off our webinar with a brief introduction to extracorporeal life support. Specifically, this example will be for congenital diaphragmatic hernia. I'm Regan Williams, a pediatric surgeon at LeBonheur in Memphis, Tennessee, and the trauma medical director, and have been one of the co-leads for our APSA SBS partnership, looking at pediatric vascular surgery. I apologize for taping this in advance. I'm going to be in a plane. I'm not sure if it's going to work, so I wanted to go ahead and get it recorded so that there would be no hiccups with our Wi-Fi. So just briefly, I want to talk about CDH and ECMO. CDH mortality over time has been relatively stable, but the introduction of ECMO has definitely improved mortality since 2013. And up in the top right corner, you can see there are 3 different defects. This is for our vascular surgeons out there. Most of the patients that require ECMO are going to be a C or D defect, which are the larger ones. About half of all CDH mortality occurs in an ECMO treated patient. CDH is the most common diagnosis in neonatal non-cardiac extracorporeal life support. And because of all this, about a third of CDH patients are treated with extracorporeal life support, and you can see that depicted over the last 10 years. This is a recent paper by my partner Tim Denselowitz, which just looks at the effect of utilizing ECMO in congenital diaphragmatic hernia patients. And you can see in the patients with the most severe CDHs, which is the second half of the line, ECMO does improve survival. However, if you use ECMO in patients without severe CDH, it actually decreases your survival, as seen on the left side of the screen. So now let's get to what we all want to talk about. When we think about putting a baby with congenital diaphragmatic hernia on ECMO, we have to think, what's the best approach? Are we going to go veno-venous, or are we going to go veno-arterial? Now, veno-venous has some clear benefits. It maintains normal blood flow through the body. It's going to spare ligation of the carotid artery, which is excellent for neuro outcomes. The debris from the ECMO can be trapped in the lungs, and it does not require clamping off of the circuit for a trial. The risk, however, is you are going to have to deal with a lower PaO2 on veno-venous, and this may be inadequate support for a patient that's in cardiac arrest or has a significant cardiac strain from their congenital diaphragmatic hernia. In a review of septic non-cardiac patients over 10 years that looked at VA versus VV ECMO, you can see there were over 4,000 ECMO runs. There's a 75% survival with VA and a 64% survival with VV. The veno-venous method did show improved survival when adjusting for age. However, the veno-venous method approach showed improved survival when adjusting for age, use of vasoactive medications, and advanced respiratory support, and that was an odds ratio of 2. And so there is some benefit to veno-venous with survival, as well as maintaining blood flow to the body and to the brain. Now, veno-arterial on the other side has some clear benefits as well. You're going to have more support, so you have better oxygenation and lower PaCO2. The risks, however, really are related to sacrificing the carotid artery and the neurologic injury that can occur after, as well as clots that could be brought into the arterial system on VA. And then it's hard to get a true assessment of ability to survive off ECMO because you have to clamp off the entire circuit, which you can't actually do with the VA. Here's another review of ELSO data that just looks at neurologic injury, and you can see that it's much higher in VA patients because of the carotid artery cannulation. Now, if you're going to decide on your approach, you're also going to need to decide if you're going to do percutaneous or open approach. And here's just some data that looks at PERC versus open. In general, probably half the pediatric surgeons do PERC or attempt PERC, and half do open. I try to use a weight or age-based strategy, where in the younger babies, I'm going to do open so I can see the vessels and clearly put the cannulas in. But in the older patients, percutaneous works great. And this is just a few studies that shows your increased risk of complication in younger people if you attempt percutaneous approach. Now let's get on to cannulation. So if we decide to do veno-venous, the cannulation site we're going to use for a baby with congenital diaphragmatic hernia is really going to be the right internal jugular vein. And we're going to use the double lumen single cannula. This can be 13 or 15 French, depending on how big the baby is and what size you can get in. There's been a couple different cannulas that we've used for VV and babies, and it's recently changed from the Avalon, which you may have used or heard of, or used in even adult patients. There was a lot of complications in children associated with the Avalon catheter, and it has mostly been abandoned. And there's a new cannula that you can see here called the Crescent. The Crescent in a baby is meant to stay in, to land in the right atrium, so it's not a bicable in the smaller babies. It has a softer catheter tip, lots of radiographic markers so that you can place it under flora and get an adequate position, and so far has been considered safer than the Avalon cannula. You're going to want to decide what size to use based on your vessel size. This can be estimated by weight. Yeah, this is the stuff that I just said. So older, we used to use Avalons. They called subperforation. So now we're using the Crescent. Here you can see the two Crescents. In a younger kid, we're going to use the 13 French, which sits in the right atrium. But in older kids, where you can fit a 15 or 19 French, we're going to use the dual lumen catheter that actually does go through the SVC and land in the IVC. That is, both are going to be placed with fluoro, so we know exactly where they are. If you're going to do percutaneous VV technique, you can see here any baby less than 17 kilograms should use the right atrium, and anything greater than 17 can use the bicable. And this is an example of a protocol that was started at Indiana University. So I want to thank Brian Gray in advance for the use of some of his slides. Now, if you're going to do percutaneous cannulation, you can either use fluoroscopy or echo to determine cannula position. And I think as surgeons, we really love using fluoroscopy and are very comfortable with it. But echo is a similar method depending on what your availability is at your hospital. Here's some x-rays just so the ideal position of the double lumen cannula. This one you can see is a little bit too high. This one's a little bit too deep. And this one, it's kind of hard to tell exactly where you are. Here is looking at the wire under fluoro when you're placing these percutaneously. So if you're going to do a bicable, you need the wire to go all the way through the SVC to the IVC without kinks or loops. Here you can see that the catheter position is too low. You could possibly cause some damage to the heart with the rubbing of the cannula on the atrium. And then on the right, you can see that this is the catheter is too high. This is the correct placement radiographically with the markers you can see. And then here's a pictorial that shows the cannula ending right in the right atrium. And then you can also see that the flow of the blood should go through the valve into the ventricle. And so you want to make sure that you have it angled in the correct position as well. Here's another example of the catheter orientation, making sure that your reinfusion port is directed toward the tricuspid valve. The valve the port is located away from the valve and therefore might cause some problems with flow. You can also use echo, and here's some examples of the POCUS technique, what the cannula looks like in the IVC. And then here's some radiographic examples of the X-ray versus the echo. Now, if you're going to do veno-arterial in a baby, we're not going to do that percutaneous. We're generally going to do those open. You have 3 different cannulation sites to choose from. We most commonly in a diaphragmatic hernia patient would do the right IJ and a right carotid. You can see here in an ELSA review, most of our patients, most children put on VA are going to be put on via the carotid artery. However, you can do a central cannulation or a femoral. Here's just a pictorial of the anatomy. We're going to make a transverse incision in the right neck. We're going to find the platysma spread either medially or even through the platysma until you identify the IJ and the carotid. And then you're going to put vessel loops around both the vessels, make arteriotomies and venotomies, and place your cannulas under direct visualization. Here are your insertion distances. I think these are just good things to remember when you're putting a on. The artery needs to be at the brachiocephalic origin, just 2.5 to 3 centimeters. The vein needs to be in the inferior aspect of the right atrium, which is 6 to 7. And then if you're using that double lumen senile cannula, you're going to be in the mid-right atrium at 5 to 8. Once you get the cannula in place, you definitely want to make sure that you survey it because they do move. There's a lot of movement, a lot of swelling, a lot of things going on with these babies. And so there's lots of different ways to do that. Most people do that with X-ray, but you can certainly follow these with echo as well. All right, now I'm going to leave it to David to answer questions.
All right, so I don't know if thanking a person on a video recording is the same as in person, but I thank you, Regan, for that. Let me pivot to kind of a very brief overview of what ECLS is in the pediatric population. Again, mostly I think aimed at our adult vascular surgery colleagues for context. This is the ELSO is the Extracorporeal Life Support organization, which maintains a voluntary registry of cannulations. This is just 5 years in North America, which is principally the United States, giving a scale of the number of annual, annual, so about 1,000 neonates and about 2,000 pediatric aged patients, anywhere from really 30 days to teenagers, being placed on ECMO. Why do we place kids on ECMO? There's, I think, a big two buckets would be congenital disease versus other. And as you can see previously, there's certainly a large proportion of these that are placed in the cardiac population, anywhere from a third to half. In the neonates, meconium aspiration, which has gone mostly out of favor due to better neonatology care and awareness, but still comprises a portion of what we do. Congenital diaphragmatic hernias, as Regan talked about or discussed, and also other versions of pulmonary hypertension, primary lung pathologies, where there's gas exchange problems, and sepsis probably comprise most of the neonatal indications. And in pediatric, you add respiratory failure, sepsis, and a catch basket of hypothermia, toxic ingestion, and even sometimes trauma. And then there's also a question of, are these treatments or allowing treatments to happen, or a bridge, and probably more so a bridge in the congenital heart population than in the non-heart cardiac population. How we approach this, I've certainly had some adult colleagues say to me, how in the world do you guys get away with occluding and maybe ligating the carotid? But that's been tried and true for a long time. We ask about peripheral versus central. Central, of course, being mostly in the cardiac population, but there is some data that central access for sepsis may be the right first choice. We talk about going through the neck or the groin, and even some through the axillary artery. Percutaneous versus open, as Regan alluded to. A chimney is a little bit out of my wheelhouse, but there are certain ways to add a chimney, a Dacron graft or other, to allow both pro and retrograde flow, particularly in the groin. There are a couple of reports about vessel sparing techniques, which are certainly interesting, particularly in the arteries. How do we place reperfusion cannulas? And triple cannulation simply means adding extra venous cannulas for better venous return. In terms of percutaneous, I think that for most adult vascular surgeons, percutaneous access is kind of tried and true. And indeed, if you look at adult reports, this is eCPR specifically, but it could be just as well for any kind of ECMO. A large proportion, almost a near, not all, but many, the great majority are placed percutaneously. That's the red line. While in pediatrics, this is a little bit out of date, but Sarah Cairo, who's now at UCSF, wrote this paper a little while ago using ELSO data, and it is a little bit out of date, but you can see we're far behind, I think, adults, percutaneous being just over 20% in 2015. Now, admittedly, these include a large portion of neonates, so kids that are anywhere from 2.5 to 3.5, 4 kilos. So perhaps percutaneously accessing the carotid is a little bit more of a challenge, or a lot more of a challenge. And I think these numbers have changed over time, but it's certainly not as widespread as it is in adults. I think Regan basically covered this. These are the different cannulas that we use, really focusing on getting the jet to go into the right atrium, across the tricuspid, into the right ventricle rather, and making sure we have good return. I think for adult surgeons, this is a tried and true. These are what we might use for reperfusion cannulas, either prograde through the SFA or retrograde through the posterior tibial. 5 or 6 French typically used. Pretty typical setup for a groin. There are some data, I think, that we want to split the venous and arterial access to prevent additional hypoperfusion distally. And I think good enough data to support a very aggressive use of prograde reperfusion cannulas, really at the time of cannulation rather than in an as needed basis. These are just the schematics. And then I might ask actually John White or Don, if or anybody might make any comments about, I think this B picture is probably unlikely to put an interposition chimney graft, but how useful or not useful or common would it be to use either an axillary or a femoral arterial a chimney graft to help provide some prograde perfusion as well as retrograde?
I wonder if John has comments, at least in the pediatric space. I'll let him start.
You know, David, I like the use of chimneys when possible. You know, unfortunately at our institution, frequently it's such an emergency that we don't take the time. We will certainly with axillary and femoral want to use prograde perfusion, distal perfusion cannula, sizing that as large as we possibly can in a way that doesn't interfere. But I do think, I do not think an interposition side branch graft makes much sense. I think that's a lot of surgery when you're being done for someone who's in deep trouble. But if you can afford it, especially with the axillary, just for the way the cannula can lay, I do like using a chimney.
And just as an anecdote, I remember very vividly when I was a new attending in Chicago, we had a young teenager who was quite obese, morbidly obese, and really had no access in the neck or groin. And our cardiac surgeons actually cut down in his axilla and put in a chimney graft. That was a tour de force. But I think as Dr. White alludes to it, in a hurry or in an emergent situation, this is not an option. But just to mention the possibilities. And as I understand it, you can actually have hyperperfusion distally, which needs to be addressed sometimes with banding or something like that. But that's even more complicated.
Right.
So David, we've done several chimneys, and the over circulation has been a problem even with prophylactic banding. And so we matter of fact, we've only had one patient that did not need fasciotomies after this, and so we're back to antegrade perfusion cannulas.
And are you putting them in percutaneously under in a hybrid suite, or are you doing them sort of all open, or how does that work?
So I'm doing mine open, and I think most of my partners are doing them open. We're actually, and I can't, going back to, we're doing the arteries the cannulas very close to one another, with the hope that when we're done, we can do either a primary anastomosis or one vein patch as opposed to two repairs.
Sure.
But we're not doing it percutaneously for the older kids. Actually, we're doing the venous percutaneously. We're not doing VA percutaneously at all that I know of.
And let me ask, I'm going to jump forward. I don't want to ruin the end of the discussion, but one of the things that comes up is sort of a generational familiarity with vascular surgery. And I don't want to speak for everybody, of course, but I trained in general surgery at a time when perc access was just coming online. So we did a lot of sewing. I'm no expert, but I feel like the current generation of general surgery residents has very little open vascular surgery experience, or relatively little. And so what we find is that our go-tos for vascular access are our transplant surgeons, or Dr. Waldhausen, who just retired, which is a big loss to us. And as we get less experience on vascular surgery, just by less sewing, especially as a non-trauma center, but that's unique to Seattle, we rely on our adult surgeons to come over and help us decannulate and reconstruct, even if it's relatively straightforward patching. Can you comment in Phoenix, do you guys have enough volume that you just have enough people with familiarity, or are you asking adult surgeons to help out with complex cases in that regard?
So 5 of the 15 of us do vascular. So it's not the whole group, but it's enough that we can, usually there's someone around to reconstruct.
Yeah, so let's talk about that at the end. I really think it's so variable. It's, my line is that all vascular surgery is local. It just depends on what you have in your group and your, what other resources you have around you. I wanted to mention one interesting paper that came out, I think in 2017, that talked about a vessel sparing approach to either the carotid or the groin, and basically talking, kind of using the approach that cardiac surgeons use to cannulate. And this is a schematic where you have a purse string that's a little bit longer than it is wide. And I don't know if you can really tell in the picture here. So you have to use a Rommel tourniquet to keep this in place. But the idea is that once you remove your cannulas, you can actually just cinch the purse string closed without having to ligate or formally reconstruct with excision again in the carotid. And it was a small series, but out of their 14 carotids that they did cannulate and close this way, all 14 stayed open, half a year into it, which I thought was really interesting. They had similar data for the jugular, which is a little bit less prone to staying open, but still pretty successful. So I think this is just something to think about. I don't know that anybody actually does this a lot, and this was, but this was an interesting paper. Who is to cannulate? Well, certainly in a pediatric hospital, it's pediatric surgeons or cardiothoracic surgeons. In adults, you might say that some intensivists will do this, and there's certainly a lot of literature on interventional cardiologists doing this. And of course, there can be places where an adult vascular surgeon will help cannulate. I think when we talked in our past in our task force, oftentimes because we don't have vascular surgeons, on site at places, they have often said, in an emergency, get kids on as fast and as well as you can, and if there's a problem, we can help decannulate, reconstruct in places, for example, unlike Phoenix, that don't have that local expertise. Where physically, typically in a pediatric hospital, it happens in the pediatric ICU, sometimes in an NICU, depending on how your hospital runs things. Some places will extend that to the emergency room, but oftentimes kids who arrest in the ED or come in arrest, if they are offered ECMO, will go up to the floor. And what about pre-hospital? Well, it's a big conversation that goes on at ELSO, and probably not so much for pediatric care. This is my ideal, having a hybrid suite with all the bells and whistles, and you have, your Lucas machine providing compressions, and you have lots of help and a really staid kind of controlled environment. More likely in pediatric surgeries like this, we have a lot of people, and you have somebody trying to do compressions there under the drapes, somebody trying to provide light over the shoulder, and an anesthesiologist who's engaged. And then this is a funny picture. I think many of you know that Paris has these mobile ECMO units. They literally will come to the patient. This is a patient being placed on ECMO for an arrest in the subway metro, or the Paris metro. I don't think we're there, but we just went to the ELSO conference, and the Minnesota adult group is very interested in out-of-hospital arrest and out-of-hospital provision of care. So who knows? We're not offering this in Seattle. This was a super interesting paper that just came out earlier this year. This is from the Memphis group. These are pediatric interventional cardiologists who recounted their experience in placing, I think it was I get the numbers, 23 kids, mostly teenagers, but included one infant. And these were all percutaneous access. So I think to adult vascular surgeons, this is very, very bread and butter appearance of placing sheaths in one artery and one vein. I think one of the learning points is if you have the luxury of time, to place your prograde cannulas first, because once you occlude the proximal femoral artery, you'll have a hard time finding or confirming that you're in the distal reperfusion lane and then having this bridge. Additionally, I thought it was super interesting that they talked about their complications. This is an avulsed femoral and iliac artery. Sounds terrifying. And of course, what they did is they put a covered sheath over this. And lastly, again, super interesting to me, and maybe bread and butter to adult vascular surgeons, the idea of closing an arteriotomy percutaneously. This is a device, the Manta or something, that they said close a 21 French arteriotomy with whatever glue they use. They showed an arteriotomy closure site that had developed a stenosis and it was treated with a stent. Now, to a pediatric surgeon, maybe putting in stents into a not completely grown body is either anathema or makes us concerned, of course. But if you're talking about reducing the morbidity of a big operation and possibly treating this endovascularly, I guess that is definitely something to consider. Let me ask, I guess, David and Notrika, just because you have a big experience there, what sort of capacity do you guys have to deal with some of the complications that can happen in arterial, especially femoral access? Do you have access to see these hybrid suites? And do you guys, U5, actually do the endovascular stuff as well, or do you rely on interventional cardiologists or adult vascular surgeons to help if the need arises?
So the Mayo vascular surgeons will back us up for aortic and iliac stuff, but generally, like I replaced a common femoral artery the other day, and if I hadn't done it, one of my partners would have done it. Mm-hmm. And with a saphenous vein graft. So I don't have any of these cool toys. But just like regular bread and butter, trauma type cases, that's, sure. That's, and unfortunately we have to treat them like trauma cases because yep. that's where our experience is.
Yeah. Don or John or anybody else from the adult side, any comments? I mean, I'll confess fully, this is not anything that I do, these fancy endovascular things. I think just interesting to see what people are writing about.
I'll just make a couple of comments, and I'd say David's, Dr. Notrika's comments are really apt, because I think what you're describing in some of these cases are bailout strategies that do feel much like a trauma patient. So it also amplifies the messaging you shared earlier. You're going to rely on this assistance, perhaps, of transplant surgeons locally. We know that orthopedic and hand surgeons and microsurgeons institutionally can be of value. The fact is that human effort and resources and skill are going to look different at every hospital, and the team will convene the stakeholders necessary for response. I think the age of the patient matters a lot. And so a lot of the endovascular resources that we may have available, even if it's to bail out, are still going to be very much limited by size and platform availability. And I would strongly caution everybody around covered stenting in really young patients. Those won't have, lengthy durability. And so if they're utilized successfully, that just really requires pretty judicious surveillance moving forward. But certainly as our technologies evolve, these conversations continue to be had, and there's probably a role in a space for many of the tools, but I think they just need to be used kind of smartly. I don't know, I look at these pictures here, I look at your closure devices and some of these other concepts, and when you're talking about teenage and preteen children, I think that's super different than when we're talking about really, really youthful kids. And I don't know that there's a standard equation to follow, but certainly there's a role for endovascular and bailouts, but I would just strongly caution people routinely stenting children.
Sure. Can I call on Dr. Drudy, who has a hand raised?
Hi, do you hear me well?
Yeah.
Okay, great. I guess my question relates to the antegrade perfusion catheter. At least in the adults, sometimes they work, sometimes they don't. It's very hit or miss. Have you noticed some issues in the pediatric population with those perfusion catheters?
Well, certainly it's not 100% success, right? In our relatively limited experience here in Seattle, I think that we've had a couple where we placed retrograde through the posterior tib that didn't work well, and we converted to prograde. They happened to be kids with sort of very, very small vessels, but maybe that's not related. And our approach has always been to always put them in as soon as possible. There are definitely reports of places that only use them as needed, which makes me a little bit hesitant, but I guess you can monitor closely and see what happens with the perfusion. Maybe there's flow around the cannula, but usually our cannulas are fairly occlusive. David, you want to comment on the Phoenix experience? I keep on calling on you, but certainly anybody else can.
I'll let somebody else comment first.
Well, we haven't had trouble with clotting of our prograde cannulas if the circuit remains without clots. The challenge we've had on ECMO is if the filters begin to clot, you will lose your prograde cannula, since that's the smallest cannula that's placed. But we haven't really had much trouble, and we tend to place ours just as David does, open into the origin of the superficial femoral artery, close to where the distal common femoral artery, close to where we will place our arterial catheter?
I think our results have improved now that we're monitoring the flow in the separately in the reperfusion cannula, and that it is shocking how easy it is to overcirculate. Even with a retrograde reperfusion cannula, an 8 French cannula in a kid will often be way too much. And so being able to monitor how much flow is going to the leg has been a game changer for us. We have some type of ultrasound thing they put on it and says this is how much flow they're getting.
Cool. All right, let me go on to Regan's next presentation. This is a different patient, an 8-year-old with hypothermia. We see this, I mean, obviously here in Seattle, not as much as you might see in Chicago, but certainly there's a small proportion of kids who may benefit from rewarming actively through a circuit. And I'll go into Regan.
All right, thanks, Dave and Dawn, for that overview. Another case presentation. This one is going to be slightly older and slightly different than the last one we talked about. This is an 8-year-old patient that was found down in the snow. There were no external signs of trauma, and this was an unwitnessed event. So briefly, we want to think about hypothermia. ECLS rewarming is indicated with accidental hypothermic cardiac arrest when there's a potential for reversibility. I found this hope survival probability. I'm from Memphis, so full disclosure, we don't have a lot of hypothermia, but the point of the case really isn't the hypothermia. It's the cannulation and the steps after cannulation to ensure good blood flow that we'll really be discussing. But I did want to include this just in case you do live in a northern state and hypothermia is something that you deal with all the time. You can see over here on the right, this is the HOPE score and how it's calculated. And the HOPE score is mostly used in adults, but can be applied to children with the caveat that children often will survive or have better outcomes than adults will. So in this 8-year-old found down with hypothermic cardiac arrest, what type of ECMO are we going to do? Veno-venous or veno-arterial? Well, you remember when we talked before, if we have a patient in cardiac arrest, we're going to need to do veno-arterial because the veno-venous isn't going to give us enough oxygenation, which you all well know. And when we think about veno-arterial, we have 3 places that we can place the cannulas. You can do a carotid cannulation, as we discussed in the baby with congenital diaphragmatic hernia. You can do a central cannulation, which is often used in our babies that have cardiac issues or disease, or you can do a femoral cannulation, which is good for our older, bigger kids. It decreases your risk of neurologic complication, but has its own set of complications associated with it as well. So for this patient at 8 years of age, we would probably go femoral initially, as long as we ultrasound the vessels and we think that they're big enough. And here's just another depiction looking at different sites of veno-arterial cannulation and different size and age babies. So we've got our central cannulation on A, D, and F. We have our carotid cannulation here in B and E and G. And then you can see here C is our femoral artery and femoral vein cannulation. And then you can also see the reperfusion cannula in this picture, which I really loved, and we'll discuss that a little bit more. So when we're thinking about veno-arterial cannulation, we really want to pick a site that depends on the cannula size. And so every ECMO program is going to have a table with cannula size and flows that these cannulas will give. And so based on the patient's weight and the amount of flow we think we need, we're going to pick a cannula size. And then we're going to see what vessels we think those cannulas can fit in. I always try to put the largest cannula that I can put in safely, but the ECMO team is always pushing me to go larger than sometimes the vessel will take. So you got to have a balance there. You can use the carotid or femoral artery and veins, but in this 8-year-old, the femoral artery will likely be big enough to give you a cannula that can support the flow that this patient needs. Just a rule of thumb, femoral vessels can be used when patients are greater than 10 kilograms or greater than 2 years of age. Of course, that's not always true. Some children are bigger or smaller than others, but this is just a good number for you to target. Again, this can be done open or percutaneous, as we discussed with the infant that we talked about earlier, though I'm more likely to do a percutaneous in an 8-year-old than I would be in an infant based on the papers that we talked about earlier. So for femoral cannulation, the venous cannula is going to be placed in the femoral vein, and it's going to sit in the IVC. It should be pretty high in the IVC above the level of the hepatic vein for adequate drainage. Our arterial cannula is going to enter through the femoral artery, but it's going to sit in the iliac artery. And you can see here on X-ray just the cannulas, the artery, the smaller one here, and then you can see the larger venous cannula going up to the liver. So it's really important when you're thinking about femoral artery cannulation to wonder how you're going to perfuse the leg. And early in my training and when I was attending, we would put an arterial cannula in the leg, and then we would monitor the leg to see if we had good perfusion. And sometimes we did, and sometimes we didn't. More often, as we started to put older children on ECMO, I've really noted the need for a reperfusion cannula in almost every single patient. And so we prophylactically do it at this point because once you need it, it's really hard to find the pulse and even pulsatile flow with ultrasound to get that reperfusion cannula in. So we find it easier to just go ahead and put it in when you're doing the initial cannulation at this point. You can see here in the right, here's a 14 French ECMO arterial cannula. You can see the 5 French antegrade cannula that's going opposite it. This is going to go into your superficial femoral artery. You can often do that under ultrasound. And then the reperfusion cannula is going to be wide into the circuit, so you're going to be getting good oxygenated blood to the distal leg. And then also you can see here this patient has a triple lumen for venous access, and then the venous cannula is in the groin, in the femoral vein on the other side. You also can do a cut down of other arteries in the leg per perfusion. You can see this is an example of a posterior tibial artery cut down that was done with an open technique to allow for oxygenated blood to be placed within the leg. If you decide to do a reperfusion cannula after you've placed the cannula and you have some leg ischemia, think about doing fasciotomies. There's often a lot of swelling and edema in the leg that does come with a cost, as most of these patients are going to be heparinized depending on their size. So that's why we at our institution have decided to just prophylactically place reperfusion cannulas at the time of femoral artery cannulation. This is another technique that I've heard about and definitely seen some presentations on, but not something that we've done at our center. But this is considered a vessel sparing cannulation. So this would be utilizing a graft to the femoral artery so that you can allow for flow to the distal limb. This is often called like a chimney graft, and I'm sure the vascular surgeons are probably more comfortable with this, or this is more commonplace for you than it is for me, but you would sew a graft directly to the artery itself, and then the cannulas would be placed within the graft for the circulation. If you do this, you're going to hopefully keep good flow to the leg, so you're not going to have to deal with a reperfusion cannula or the risk associated with leg ischemia, which sometimes can cause a lot of tissue loss if not noted early and quickly. I think this one should have a few more questions, and I'd be interested to hear everyone's experience with distal reperfusion cannulas and the best way to place those, and then also anyone's experience with vessel sparing cannulation. I know there are a lot of pediatric surgeons that utilize this technique, so I'd like to hear from everybody. Thanks.
Okay, so we kind of did it backwards, but I'll reflect back to Regan what we talked about. If I may, I'm going to talk briefly about the next topic is about sort of follow-up and what happens to arteries after we decannulate kids from the neck. There's an option to ligate the artery, the carotid, or to reconstruct it. And in the groin, of course, you're almost certainly going to reconstruct if with the patch, although sometimes I guess if you have a percutaneous access and can close it primarily, that can be an option too. But we were interested in finding out what happens to those reconstructed arteries in terms of flow, and just presented this at also last, I guess a couple of weeks ago. The ECLS registry for the last 2 decades had close to 800 cannulations. And when we took out those who were central and those who did not survive, you're down to, we had 362 cannulations. Of these, about a third were reconstructed. And of those, we only had imaging for a third, a little bit over a third. And it was very short-term follow-up. So that's an important note. It's only 3 weeks. However, 45%, about a third of those 21 were occluded, and the other 2/3 had intimal changes, a little flap or a raggedy edge. And we thought this was notable. It's a large proportion, but in full disclosure, of course, early intimal changes may not mean anything in a year or two. But we thought we don't have enough data to say, can we ignore it or not ignore it? Similarly, in the groin, we had 21, 2/3 of the 33 were reconstructed. Higher proportion of imaging and a lower proportion of intimal changes, but still not insignificant numbers. And of course, in the leg, we worry about in a carotid, we worry in theory about a stroke risk in the future, and in the groin, we worry about leg limb length discrepancies. And we did as much as we could looking back at data to see were there risk factors for occlusion or intimal changes, and only really found that the younger the patient, the more likely they were to have this. That kind of stands to reason. We didn't find anything by duration of ECLS, which some papers have suggested as a risk factor for post-reconstruction narrowing. Didn't really find much else in terms of patient demographics or backgrounds or medical indications. And then looking at the sequelae of cannulation, so ECMO was first described by Dr. Bartlett in 1972, and a couple of decades later, people started writing about this idea of reconstruction after decannulation. So, why leave a carotid artery ligated? And then the next wave was sort of the aughts and 2010s, talking about the importance of follow-up and trying to push out that follow-up to more than just immediate post reconstruction imaging. Again, I think that adult surgeons will often ask me that, how in the world can you justify ligating the carotid? It's an important question. Of course, we're relying on a complete circle of Willis, which is incomplete about 5% of the time. Early on, there was a pretty high incidence of intracranial hemorrhage and infarction. I think those numbers are better now, but not zero by any means, of course. And it's probably a combination of underlying disease, ligation, heparinization, and perhaps lack of collaterals. So it does certainly come at a cost. Again, first reports of reconstruction were in the 1990s. There was an interesting report from radiology looking at neonates and measuring MCA velocities with Doppler. And while the right MCA velocity went to almost nothing, of course, during ECMO, after reconstruction, the MCA velocity rebounded pretty quickly to normal. Now, you could argue that reperfusing an ischemic brain is not a great idea, and I think it's both a philosophical and a practical question. I know that Dr. Quiroga is on, I think, and she's one of our University of Washington vascular surgeons who's particularly interested in carotid trauma. So I might call on you, Alina, a little bit to ask to comment on that kind of thought, although these are neonates and they're obviously very different than the populations we see in the older patients. So technically feasible, clearly feasible to put two ends of a carotid back together. Reproducibly increases blood flow, but no clear association with reperfusion injury, meaning those neonates that were reported didn't suddenly stroke or have big bleeds, but we don't know what the long-term sequelae are of reconstruction. Next wave, mid to late 90s. There were some now reports of following these carotid arteries, reconstructed arteries out a few months or even a couple of years, but there's incredible variability in the outcomes reported. Does narrowing persist beyond that first initial time? Well, one paper says no, one paper says yes. One paper says diameter improves over time, meaning the narrowing goes away. And some of them would pair these with imaging of the brain through MRI and neurodevelopmental testing, and there really was no matching. Now, most of these studies were very limited case series and very much of a selection bias. Which cases do you reconstruct? Was it, and why do you reconstruct them, and in whose hands? These are just some of the folks who would be familiar to the pediatric surgeons here. And so then the next wave, so it can be done emphasizing the resection of the middle segment of the artery where it may be necrotic, so getting a healthy end-to-end, that stands to reason, and very variably reported degrees of stenosis. One more wave, there are a couple of papers that were interesting that showed longer follow-up, but again, very, very much biased in the sense of, or at risk for bias, selection bias. This group reported in carotid artery reconstruction that majority remained patent at 5 years or so. There were fewer MRI abnormalities and perhaps decreased cerebral palsy, but it was really at that 0.05 p-value, and it was a fairly small group, obviously. I really thought the paper suffered from selection bias because, why do you reconstruct? When do you reconstruct? And then this is a super interesting paper that's not exactly related, but it's sort of related. Looking at teenage survivors of ECMO who had their carotid artery ligated, and they had ultrasounds of both sides, and they found on the left side, meaning the contralateral carotid head, a significant increase in the carotid intima media thickness. So this is kids who may not have any specific genetic predisposition to intimal media thickening, and yet had perhaps compensatory. So I might just pause for a moment and ask maybe Dr. Quiroga if you can make a comment about what you and I had talked about. Does this present stroke risk in the future? Is there a way to quantify that? Is there something we should, how would we interpret this sort of second study?
Hey, thank you so much, David, for inviting me to talk. As you know, the first time that we talked, I was shocked about the fact that we're ligating carotids, but after I reviewed the data, I actually think that's equiposed, and it's difficult for me to say which one is better. Regarding the intimal hyperplasia, the thing that we talked about, should we have these patients, what's going to happen in the long term run? We would say, you guys save these patients' life. What's going to happen when they're 30, 40, 50? And should we do a better job about telling these patients to don't smoke, maybe start lipids earlier if they are increased risk for stroke than other patients? And I think that's the next step in our work.
Yeah, Don or John, or I want to open it up to anybody else, but this idea of, does one interpret this Friedlich study as a really a worrisome study in terms of future stroke risk, or is it? Clearly we need more data, but or is this just like a fantasy that I'm misinterpreting?
Yeah, I think at least there's a reason or opportunity to follow them carefully, because intima media thickness is just the precursor in adults for future disease, but at least this is something that is easily followed by duplex scan, and if it becomes significant, then we can obviously address it, as by that time the children would have grown almost adults. So I think that may not be such a big issue. But what I was about to ask you is, has anyone tried the chimney technique for the carotid so that we don't need to ligate?
I think there's these reports of a vessel sparing, kind of almost like the cannulation that the cardiac surgeons use in the aorta. It's obviously hard. We're looking at a carotid artery that sometimes will barely take an 8 or 10 French cannula. So it's really, I don't know if, and we're often doing it under stressful situations. And I mean,
right.
stress for us, but rapid. Trika, can I ask your opinion? Like, not opinion, but well, both. But do you guys have any kind of set ECMO follow-up paradigm, or is it more one-off? Or maybe he had to leave, but anybody else from pediatric surgery, do your programs have a standardized ECMO, aside from the neurodevelopmental stuff, which I think a lot of pediatric hospitals do very well, but I haven't really seen many people do a codified approach to vessel monitoring.
David, I want to add just a couple of comments for this discussion. And the first is that I think this is where your long-term data is going to be so important. And I'm curious if the intima medial thickness is a result of trauma and the neointimal hyperplasia that might ensue. We see this as an important marker to follow for our renovascular hypertension patients. And there can be some favorable remodeling, we think, after the hypertension is absolved, much like you would anticipate left ventricular hypertrophy and other cardiac metrics to remodel favorably. So I agree with Dr. Babu that this is kind of marker that warrants follow-up, simply because we know as these patients progress into adulthood, perhaps we see this as a marker for cardiovascular disease burden in the future. One other consideration just around your carotid cannulations to think towards, and we've talked about this, but I can think of a couple anecdotal patients that have come to me in a pediatric vascular clinic diagnosed with atrophy of a carotid artery. So really small vessel lumens, although patent, and concern around whether or not they require reconstruction. And I can think of two cases in particular that presented referred for that reason. And on further history and questioning, it became clear that they had been cannulated for ECMO and had scars on their neck. And so my assumption is that they probably had a ligation or some type of procedure around their cannulation that resulted in that. And were these cases of occlusion that recannulized over time or not? All of them, obviously, I managed conservatively, but it does raise questions around what the long-term sequelae are. And I think the work you're pushing forward is so important.
Yeah, I think we have a lot more to learn about this. I'll just finish up this. Let's see which button I need to push. A little summary here. There actually happened to be 3 papers published this year that were systematic reviews or some sort of literature reviews about reconstruction. And really, they basically said that, there's no great data, a lot of non-comparative outcome studies, patency rates are all over the place, and nothing really to help us decide between the two approaches regarding neuro outcomes. So it seems to me that a lot of the literature says that it supports the idea that you don't need to reconstruct to help with neuro outcomes, but I'm really curious what we're going to find out by studying our patients into their teenage years and the 30s and 40s years about what happens to their carotids, whether they're ligated or not, what happens to the other side, or in the groin, does the contralateral artery, probably less likely in the groin, but it would be interesting to see. Of all these papers, I'll just mention one other thing. This is the Linden paper that looked at the Children's Hospital Neonatal Collaborative or whatever that C is. And they just interviewed people at 37 big hospitals about what they did with after decannulation in the cervical approach and anticoagulation. It's really all over the place. And not surprisingly, but notably, it's sort of inverse. The pediatric surgeons tend to mostly ligate. That's the light gray on the left. And then the dark on the right is the pediatric surgeons who ligate, whereas the cardiac surgeons will tend to repair vessels almost inversely in proportion. And also anticoagulation after a vessel repair is all over the place. I was actually really surprised to see that 60% of patients are not anticoagulated after reconstruction. It's a very small numbers, but not zero. These are centers rather, not individual numbers. A lot of places will use aspirin. Some places will use aspirin and heparin. Again, speaks mostly to the variability, which to me means we don't really know what we're doing. And I mean that disrespectfully. I think we just have a lot to learn. I'm going to. I wonder if we might skip this one because Regan's second presentation really addressed the femoral reconstruction part and the cannulation part. I might just ask Dr. White or Dr. Coleman, in addition to what we talked about previously on a 15-year-old, I think that we would all prefer to use the groin rather than the neck. We talked about a lot of these different questions or statements. I think there are some data about central cannulation for particularly in sepsis, particularly in gram-negative sepsis, where you just need incredibly high flows. We didn't really talk about anticoagulation. Maybe you guys can make a comment about what would be a sensible anticoagulation paradigm for a reconstructed femoral artery, assuming there's some sort of patch or other.
I continue it, at least while they're in the hospital, so the presumption is these children will be in the hospital for a while. As long as I can observe for any signs of bleeding, I have a very low threshold, if there's no other contraindications, to therapeutically anticoagulating them until they're fully mobile. And then I might break down to an antiplatelet agent.
And for how long?
By 3 months, they're all healed. Mm-hmm. So I tend to use the sort of a 3-month time frame.
And do you have an approach to following them with imaging for how and how long?
Yeah, and I plug them in. So I would see them every 6 months, for a long time. Generally, you lose them if they go away to high school or they go away to college. But, I tend to be pretty compulsive, as I do with all my lower extremity revascularizations, and they get ABIs and a duplex imaging of the site.
Yeah, I think it, to me, it seems so rational and critical, and yet we don't do it. So that's one thing that we hope to generate some data on by calling back our reconstructed survivors from Seattle locally. We're trying to get some grant funding for that, and then also having some, partly through this collaborative between our societies, to really think about how we can codify follow-up and generate some data there. So I'll end with, before we just open up completely wide open, and just ask about what follow-up should look like. These are sort of the two big publications that ELSA uses. ELSA has called a Red Book, which talks a lot about technique of cannulation. It talks a lot about the medical side, and they do have a chapter on follow-up, but it doesn't mention anything about vessel follow-up. And then a relatively recently published guideline also mentions it's all about neurodevelopmental follow-up and medical follow-up, which of course are super important. But I'm in touch with the senior author here, one of the senior authors here, to make a pitch that we formally put in recommendations for imaging follow-up, which I think would be really important to do. And then to me, and I'm curious what other people think, I think vessel-specific follow-up would include imaging and growth, particularly in the leg. I'm curious if we'll find any data from our own review, but I assume there's going to be some sort of genetic and biochemical impact, not only our diets, but our biochemical profiles, and who is at additional risk, and specifically for stroke risk. And do we plug them into stroke risk assessment? Maybe that's not the right, I'm sure I'm using the right phrase, but to have a passport. And as Dr. White pointed out, it's hard when kids leave the house at older teenage years to keep them plugged in, but I think it's important, and I hope that they can get that follow-up. I was trying super hard to keep on time. If people have the energy, we have nothing else specific. I think these are the themes that our group talks about, our collaborative SVS, APSA. We talk about how all vascular surgery is local, so you have to think about your local resources. We talk about the the idea that there are some barriers or hurdles, credentialing, billing, call schedules. How do you provide care when you're based somewhere completely different? Certainly not limited to ECMO. We have a huge array of interesting topics of interest. And you can look forward to, I hope, a publication, a joint publication with JPS and JVS in Q2 of this coming year, looking at a whole bunch of things like trauma and vascular access and iatrogenic trauma and compressive syndromes and other things. We've talked about how can we increase experience for those interested pediatric surgeons who want to get a little extra training in vascular surgery. We talked about a registry, and we haven't, but we might talk about device development. How do you adapt, rather than not adapt, but innovate in the space of pediatric surgery, which is obviously a very, very small, it's almost like an orphaned population when you look at big picture and big money, but hopefully a deserving population. I've been talking a lot. Apologies for that. I'm going to open it up for questions, or maybe Dawn and John, do you want to lead with anything else that we should address on this time?
I don't want to lead a thing. I simply want to thank everybody for being part of tonight's discussion. This is the first kind of collective virtual concept that we've built out. And one of the things we'd really like to garner from all of you and others that are part of our interest group listserv are other topics that we should prioritize in the future. And so I do think we should have an open discussion with everybody here who has touch points with these patients, but just a gentle nudge and reminder that we'll follow up an email after this session, just looking for other topics of interest to our interest group members, and propose that I'm hopeful this quarterly cadence will persist. We've agreed that around every quarter, the APSA and SVS teams respectively will kind of co-lead the next session. And so I anticipate that we'll come together again sometime after the new year. And our vascular surgery kind of membership will probably identify and take the lead on additional topics. And our goal really is to sprinkle in some anecdotal cases for consideration and technical considerations and the available science, acknowledging that may be limited, but also try to engage others outside of our core task force that can help share their expertise and experiences. It's been very clear in learning from everybody that different institutions really do what they can to maximize their local resources, and that looks really different across the landscape of care our children receive. So please stay engaged with us and share both your topics of interest and volunteer if you're willing to help kind of take the lead on some things. And we really are excited to carry this forward as a meaningful educational interdisciplinary endeavor as a team. So I just wanted to say thank you to both Dr. Rothstein and to Dr. Williams for really leading tonight's charge, and to everybody that has shared their pearls of wisdom and expertise. I'm looking forward to a discussion, and I'll just kind of mute myself and observe, but thank you guys so much. I think Dr. Stanley may have put his hand up.
Thank you.
Dr. Stanley, can you unmute, please?
That's interesting. He was unmuted.
Oh, it's too bad. Sorry, we'd love to hear what you had to say.
Let me throw just this question out to the pediatric surgeon. You know, there's in the adult trauma literature, there's a suggestion that you should repair an injured carotid artery if you can gain access to it. So, you know, if it's not in the chest, so you don't have to crack the chest, and it's not at the base of the skull. But as cervical carotid, rule of thumb is repair it if you can. Otherwise, the stroke risk is there. Now, so that literature pretty much is built on the older adolescent, you know, to the adult. Is there an age at which pediatric surgeons would not cannulate a carotid artery for risk of stroke? I mean, in a 15-year-old, would you still look to cannulate the carotid artery at some institutions?
I think it definitely would happen at some institutions. It happened in Chicago when I was there. I think we are at least gaining a recognition of how to do the. I mean, part of it is just familiarity, right? Places, again, generationally and cadence-wise, are only cannulating the groin once a year. I think there's a lot of anxiety about that, whereas the neck is sort of familiar territory. But I don't have data to say this, but I think that most of us would say, after age 5, 6, 7, most people would consider going to the groin. I don't know, David or Marion, anybody else who want to corroborate or completely dispute that? Not dispute that, but just like what your experience has been.
So I think the risk of stroke for the first 4 months of life is 0. And then there was a recent publication that showed that the risk of stroke is very, very low up until another age that was a lot older, and I can't remember what that age was. So I personally start getting nervous at cannulating after about age 4, you know, through the carotid, and by the time they're teenagers, we're definitely going to the leg.
Right.
So can I give you an exact number? No. Sorry.
So the lung age, the younger age, seems reasonable to me. Where we really began to question what we were doing came with COVID, when we were putting more patients on ECMO. The question was if they were in our children's hospital, people started reaching for the carotids. I would certainly get uncomfortable and sort of suggest that, if you give me a minute, we'll just do it through the groin. Because of the concern, not necessarily the concern of the ECMO process, but more the concern of the decannulation and what we would face would we be forced to ligate, et cetera. Because I do believe, as Dawn has suggested, that if you truly damage a carotid artery, it will regress a little bit. If you really injure the wall with a lot of pressure necrosis, eventually that carotid is going to scar down. So that we really began to push our limits of carotid cannulation down lower and lower. And I must admit, we're probably where you at, David, at 3 or 4 now. If we can get a femoral cannula in, that's the way we'll do it.
I just sent something from the chat. It was an APSA survey that was done right before COVID, and so regarding the age, there were 28% of pediatric surgeons would use the neck vessels no matter what age.
That's a significant number.
Yeah.
Maybe the 72% that didn't respond were busy cannulating the groins, though.
Good point. Good point. And they only had a 21% response rate in the survey.
Look, I mean, I'll be honest. Like one of the sort of like the landmines here is that I'm saying that I feel like there's a generational shift with less familiarity with and comfort with pediatric surgery with vascular surgery. And I think Dr. Notrika's experience in Phoenix is probably a bit of an outlier in terms of having that many people that are comfortable and good at and had the volume, right? I mean, you have all the necessary components and an amazing children's hospital. So then there's lots of pediatric surgery being done at places that it's not that they shouldn't be doing it, but then they're called upon to do extraordinary things with fewer resources. And so I do think it's really important that everybody think about what's right for their patients in their hospitals and not try to reproduce something that can't be done elsewhere.
I think you're right. I don't think we're typical.
And the other thing, I would say, David, I don't know about your experience, but even when we use distal perfusion cannulas, there's a significant percentage that require fasciotomies. As we follow CPK levels, my indoor record was in a 15-year-old who, even with a distal perfusion cannula, he wound up with some leg ischemia. He had a CPK level that was my record at 130,000. And wonderful resiliency of children, ultimately was able to walk normally. But we tend to have a very low threshold, even with a distal perfusion cannula, of checking and doing fasciotomies.
Oh, great. Go ahead, please. Nope.
My last question was, from pediatric surgeons involved with ECMO for anticoagulation post-procedure, once you've decannulated. What's the anticoagulant of choice? Are you using more low molecular weight heparin, unfractionated heparin? Do you convert to orals? When would you consider using the novel oral anticoagulants in children? At what age?
Our cardiac surgeons are the ones who do the majority of our reconstructions, and they basically put kids on aspirin for 3 months, and then again, I don't think they actually reevaluate. We're trying to, again, to codify the reevaluation, but it's been 3 to 6 months of aspirin.
Okay. Dave Nutrico, what do you use post procedure if you reconstruct?
So it depends on the size of the patient, but our standard is aspirin. So we haven't had any problems with just straight aspirin. So we'll anticoagulate them in the immediate period, rather like right after the repair. So they'll be on heparin typically for a few days. Once they get palpable pulses back, so not just Doppler signals, but palpable pulses, that's when we usually switch them to aspirin.
Okay.
And I have no science to back that up whatsoever.
No one does.
Don, any final comments? I think I really appreciate everybody's sticking in for a while. So I don't know what time where everybody is, but I know it's very much appreciated on our end.
You did great, David. Thank you. Thanks, everybody.
Thank you.
Yeah, thank you all.
Thanks, everybody.
Thanks, guys, and then please feel free to message me or Regan if you guys want to add people to the listserv. We can go directly to back to Mary Bowditch here also. All right.
I just want to say this was excellent, and I think you recorded this, and there would be a lot of people that would want to, see this discussion and the talk. So, if there's a way to make it available,
we could probably post it to a link to it in the APSA 2-minute thing. That seems to get some readership, and maybe Donna can think about it.
We're gonna post it to a web page, and so it'll be available. I'm gonna have the marketing people upload it to YouTube.
Great. Awesome.
Mary, thank you. And Sandy, thanks for those comments. I want to just publicly recognize and extend some gratitude also to Mary Bowditch and Riva, who have been helping us really coordinate this task force and all of the efforts. So huge thanks for putting so much thought and effort into